Bismillahirrahmanirrahim. Today we are going to discuss the proliferative disorders of the stomach. By proliferative disorder, we mean that those disorders that involve abnormal proliferation of cells. We know that abnormal proliferation of cells may either result in hyperplasia or benign or malignant tumors. The neoplastic diseases of the stomach or proliferative disorders are divided into two types of tumors, the benign tumors and the malignant tumors. The benign tumors include the gastric polyps, and the gastric polyps are further divided into three types: the inflammatory and hyperplastic polyps, number two, the fundic gland polyps, and the adenomatous polyps are the gastric adenoma. The most common malignant tumor in the stomach is the gastric adenocarcinoma. The lymphoma arises mostly from the mucosa-associated lymphoid tissue known as the malt lymphoma. Carcinoid tumors, they arise from the neuroendocrine or enterochromaffin cells, and as we know that such cell populations occur in the stomach. The gastrointestinal stromal tumors arise from the connective tissue stroma in the gastric wall. The leiomyosarcoma is the tumor of the smooth muscle in the gastric wall, and it is a rare tumor. Now today we discussed the benign conditions known as the gastric polyps. The gastric polyps, they are small growths or masses that occur on the inner lining of the stomach and project above the level of the surrounding mucosa. Mostly the gastric polyps, they are present in the stomach and are undiagnosed. But sometimes when we introduce an endoscope and we do gastroscopy or endoscopy, for some other reason we may see gastric polyps in the stomach. And most of the times these gastric polyps, they do not cause problems and patient has no signs or symptoms. Then why we get worried about the presence of the gastric polyps? The reason behind is that some of the gastric polyps, they have potential to develop into malignant tumors later on, and therefore their early diagnosis and endoscopic or surgical dissection is must. So what are the causes of the gastric polyps? The gastric polyps, as I mentioned, that they arise because of the abnormal cellular proliferations, when there is abnormal uncontrolled division of the cells. So they may arise because of the epithelial or stromal cell hyperplasia, which is increase in the number of cells as compared to hypertrophy, in which the cell size is increased. So either the epithelial cells or the stromal cells may increase in number, causing hyperplasia. The polyps may arise in response to inflammation, and sometimes tissue that is not normally found in the stomach comes to lie in the stomach. For example, the gastric lining contains the gastric mucosa, which is composed of foveolar mucin secreting cells, cheap cells, parietal cells, G cells, and there are no intestinal columnar epithelial type of secretory cells and mucus secreting goblet cells. So this ectopia or presence of ectopic tissue in the stomach may be congenital, present from the birth, or may be associated with some genetic defect, or it may be acquired which occurs later on in life. The common cause of gastric polyps are neoplastic disorders. And the gastric polyps are generally considered as benign neoplasms. Here in the picture you can see that this is the normal gastric mucosa, this is the normal gastric mucosa, and here we can see an outgrowth from the normal line or lining of the gastric mucosa into a polyp. These polyps are sometimes becomes pedunculated. By that we mean that they have a stalk and a body, upper body which attaches to the gastric mucosa through a stalk. These are the pedunculated polyps. And sometimes the polyps are continuous and lack such a stalk. So they are not pedunculated and they are known as the sessile polyps. We divide the gastric polyps into its three major types: the hyperplastic and inflammatory polyps, the fundic gland polyps, and adenomatous polyps or adenoma that represent the benign tumor of the gastric mucosa. Now, the hyperplastic polyps, by that we mean that there is hyperplasia. There is hyperplasia of the mucosal epithelium of the gastric lining, but this hyperplasia, the cells in the hyperplastic tissue, they are very similar to the normal mucus secreting foveolar cells of the stomach. So what happens in causing hyperplastic polyps, that the hyperplastic polyps as well as inflammatory polyps, they mostly occur in the background of chronic gastritis. In our previous lecture of chronic gastritis, we mentioned that chronic gastritis has two major types: the bacterium gram-negative bacillus Helicobacter pylori induced chronic gastritis, and the autoimmune gastritis, in which the body immune system produces antibodies and there is an immune reaction that results in the destruction of the parietal cells. And the parietal cells, they secrete hydrochloric acid. We know that various populations of cells are there in the gastric glands. For example, cheap cells that secrete pepsinogen, parietal cells that secrete hydrochloric acid, the foveolar cells that secrete mucus giving protection to the gastric mucosa, particularly from hydrochloric acid, and the G cells located in the antrum, they secrete the gastrin, which stimulate the parietal cells to increase excess secretion of hydrochloric acid, and some enterochromaffin cells are also there. For example, the cells that secrete histamine, and cells that secrete somatostatin, the growth inhibitory factor. So in autoimmune gastritis, the immune reaction destroys mainly the parietal cells. However, the cheap cells and other cells may also get destroyed. So when the normal mucosa becomes infected by H. pylori gastritis, or if the cells are destroyed by an autoimmune gastritis, what happens that particularly there is destruction of the foveolar cells. These are the mucus secreting cells. So we know that the stomach epithelium or lining is formed by the labile cells. The labile cells, as compared to the stable cells and permanent cells, which are the major three types of cells that make our body. So the labile cells are those that are continually lost and are replaced by the newly regenerating cells. So what happens in chronic gastritis, that there is destruction of the mucus secreting fibular cells as well as some other cells. So it is followed by excess regeneration of the new cells. New cells are continually formed to replace the cells that are lost. And we know that whenever there are repeated cell divisions, repeated mitotic cell divisions, each division carry a risk of genetic mutations. This is very important in the pathogenesis of the tumors, because these are the genetic mutations that participate in causing a cancer in a tissue. So as a result of reactive hyperplasia, when the newly formed cells attain an excess growth and form a hyperplastic polyp. It may be small, it may be single, or sometimes multiple. These hyperplastic polyps are benign. They have no cancer cells, and under the microscope they consist of irregularly and cystically dilated glands, and the foveolar mucus secreting cells are elongated and form dilated glandular structures. Now, on gross examination, these polyps may be sessile and sometimes pedunculated. Roughly, they are oval shaped, smaller in size, and covered by a smooth surface. Now, when these polyps are simple polyps with no complications, they do not cause problems. But however, it is possible that these polyps may become ulcerated or may become inflamed. Inflammation may occur due to the uh, uh, underlying injury. So when inflammatory cells are present in the background, then we call these polyps as the inflammatory polyps. So the major difference between hyperplastic and inflammatory polyps is that the presence of inflammation and inflammatory cells. Now, mostly these polyps are smaller than 1 centimeter in diameter, and their size is a parameter for the risk of malignancy. By that I mean that polyps that are less than 1 centimeter in diameter have decreased risk of dysplasia and malignancy, while those polyps that are greater than 1.5 centimeter in their diameter, they carry increased risk for malignancy, and therefore if they are seen or visualized during a gastroscopy or endoscopy, then endoscopic removal of these follicles is advised, because in future they may progress to adenocarcinoma. So simply we summarize that the inflammatory and hyperplastic polyps arise in the background of chronic H. pylori gastritis and sometimes autoimmune gastritis. And these chronic inflammations, they initiate the injury, and as a result, there is reactive hyperplasia and growth in the foveolar cells, and they form a polyp. They inflammatory and hyperplastic polyps are the same polyps, with the difference that when there is an element of inflammation, if there are inflammatory cells present in the area, then we label them as the inflammatory polyps. Smaller polyps carries negligible risk of transition into malignancy, while polyps greater than 1.5 centimeter in size carry high risk of dysplasia and malignant transformation, and therefore if they are seen even incidentally in the stomach, they should be resected. The second type of polyps are known as the Fundic gland polyps. The Fundic gland polyps, as the name indicates, they are mostly found in the fundus of the stomach. We know that we divide the fundus into the cardia, the part of the stomach that receives esophagus, then the fundus and body are corpus of the stomach, then the pyloric antrum, and the pyloric antrum will continue into the small intestine or the duodenum through the pyloric sphincter. And we know that the cardia region of the stomach that receives the esophagus, it contains lot of mucus secreting foveolar cells. While the fundus and body of the stomach, they also contain the parietal cells that secrete HCl and the chief cells that secrete pepsinogen. Moreover, other populations of cells like G cells, enterochromaffin cells, and some other glandular structures may also be present in the gastric wall. Now, the Fundic gland polyps that most commonly arise in the fundus of the stomach, they arise in three distinct patterns. These patterns, number one, may be sporadical. By that we mean that we see the polyps randomly in few people. And we cannot associate these polyps to a particular syndrome or a particular disease. These are sporadical polyps. Now, the second pattern of the Fundic gland polyps, it is associated with the chronic use of proton pump inhibitors. The proton pump inhibitors, the omeprazole, esomeprazole, lansoprazole, and so many other, they are used by the patients of GERD and high acidity of the stomach, reflex esophagitis, and in conditions like gastritis. So patients use these proton pump inhibitors for long periods. And what the mechanism of the proton pump inhibitors is that it will reduce the acid production by the parietal cells. But we know that the gastrin, which is secreted by the G cells located in the antrum of the stomach, they will stimulate the parietal cells to increase or induce excess secretion of the hydrochloric acids. So when there is reduced acidity, it will stimulate the gastrin secretion from the G cells. And this gastrin will cause glandular hyperplasia, particularly of the parietal cells. And one important point here is that the Fundic gland polyps that are associated with glandular hyperplasia are sporadically produced. They carry very less risk of malignant transformation. The third type and the third pattern of the Fundic gland polyps are those Fundic gland polyps that are associated with a genetically inherited condition known as the familial Adenomatous polyposis. Usually in the familial adenomatous polyposis syndrome, there are numerous polyps that occur in the large intestine. But sometimes they may also be associated with the Fundic gland polyps, and here it is uh, important to mention that the polyps, Fundic gland polyps, they are associated with the familial adenomatous polyposis syndrome, have some risk of malignant transformation. These polyps may be asymptomatic, causing no problems, and sometimes they may cause problems, particularly if the size of the polyps is large or if there are multiple polyps. These are well circumscribed polyps and found in the body of the stomach and fundus. Mostly they are multiple, and microscopically they consist of cystically dilated irregular glands, which in addition to foveolar cells are lined by the flattened parietal cells that secrete HCl and sheep cells that secrete mucus. Generally, with the exception of the polyps associated with familial adenomatous polyposis syndrome, the Fundic gland polyps, they do not have malignant potential. So, we summarize the Fundic gland polyps may be either sporadic or they may be associated with chronic use of proton pump inhibitors, which are commonly used in peptic ulcer, in gastritis, in any condition leading to hyperacidity, in GERD, gastroesophageal reflux disorders, and sometimes in Barrett esophagus, and so many indications are there for the use of the proton pump inhibitors, and these drugs really actively suppress the secretion of the hydrochloric acid. The sporadic polyps, polyps associated with PPI use, and polyps associated with familial adenomatous polyposis, which is an inherited autosomal dominant genetic disorder. And these polyps associated with familial adenomatous polyposis have some degree of potential for malignant transformation. The adenomatous polyps are adenoma, benign tumor of the glandular epithelium. So what will be the malignant tumor? Adenocarcinoma. So adenoma or adenomatous polyps, they actually represent the benign growths that occur in the gastric mucosa, and particularly in the gastric glandular epithelium. And these polyps are usually located in the antrum of the stomach, which is the region that will continue into the pyloric sphincter. Again, here the transition to malignancy depends on the size of the polyp. So polyps that are larger than 2 centimeters in diameter, they carry high risk of becoming malignant and may cause transition into the malignant tumor in the stomach, the adenocarcinoma. Now, coming to the pathogenesis of adenoma or adenomatous polyps, they also occur in the background of chronic gastritis. Inflammation-induced destruction of the cells occur, and what happens that with repeated exposure to the chronic gastritis, it will lead to atrophy of the glandular structures in the stomach. And what happens that here metaplasia occurs. We know that metaplasia is the reversible adaptation in which one adult type of epithelium is replaced by another adult type. So here intestinal type of metaplasia occurs with repeated irritation and exposure to the chronic inflammation. The gastric cells, they become transformed into intestinal type of cells. The normal gastric mucosal epithelial cells that are non-absorptive columnar cells with the presence of the foveolar cells that secrete mucus. But in the intestine, the intestine is lined by the columnar type of secretory and absorptive cells. And here the mucus secreting cells are known as the goblet cells. So when the gastric mucosa undergo metaplasia into intestinal type, which is a common happening that occurs in adenoma or adenomatous polyps, this is the intestinal cell type of metaplasia. And once metaplasia occurs in a tissue in the epithelium, so over time further genetic mutation accumulates and the metaplastic epithelium may become dysplastic. By dysplasia, we mean loss of uh, structural orientation to the normal cells. Low grade, low or mild, moderate, and severe dysplasia. So, as the cells, for example, the metaplastic cells are intestinal type of metaplastic cells. When they have full similarity to the normal intestinal intestinal columnar epithelial cells, we say this is low grade dysplasia or no dysplasia. But as the cells in the metaplastic epithelium lose similarity to the original columnar epithelial cells, we say this is dysplasia. And as more and more similarity is lost, we say that now the dysplasia is moderate or severe. And severe dysplasia carries high risk for malignant transformation. So for this reason, we look for the dysplasia in the metaplastic cells. If there is low grade dysplasia, we say these low grade dysplastic cells, and they will be more similar to the original intestinal type of columnar epithelial cells. But if there is high dysplastic, high grade dysplasia, then the cells in the section or the cells present in the adenomatous polyps, they will have no similarity to the original cells. And cells with high grade dysplasia are more likely to become cancerous. So coming to the summary of the today lecture, polyps are benign neoplasms in the stomach with variable potential for malignant transformation. For example, large size hyperplastic polyps have a high potential, and similarly the large size adenomas or adenomatous polyps, they carry the high potential, particularly when they show high grade dysplasia. So the three major types of the polyps are inflammatory and hyperplastic polyps, which are more common, and they result from reactive foveolar cell hyperplasia in response to chronic gastritis. The Fundic gland polyps, as I mentioned, that they arise in three distinct patterns: sporadic polyps, polyps associated with proton pump inhibitors, and Fundic gland polyps associated with familial adenomatous polyposis. And the polyps associated with familial adenomatous polyposis have the potential for malignancy, but the polyps associated with proton pump inhibitors, they have no malignant potential. Similarly, the benign tumor, the adenomatous polyps or gastric adenoma, it also occurs in the background of the chronic gastritis, and the risk of malignancy in adenoma is associated with the grade of dysplasia. High grade dysplastic adenomatous polyps are more prone to become malignant. Thank you very much.